So I again welcome everybody. We'll be talking, as I said, about feline cardiomyopathies, how to diagnose and how to treat the various cardiac conditions in cats. Mainly hypertrophic cardiomyopathy, dilated cardiomyopathy, and restrictive cardiomyopathies. These are the three most common heart conditions in cats, with arrhythmogenic right ventricular cardiomyopathy, which we call ARVC. In my last lecture, I had discussed that ARVC is also known as boxer cardiomyopathy because it is a common heart condition in boxer breed. In cats, it is not very common. In cats, in terms of how prevalent all these diseases are, top on the list would be hypertrophic cardiomyopathy, which is the most common cardiac condition in cats. It is followed by restrictive cardiomyopathy and then dilated cardiomyopathy. In contrast, when we spoke about dogs in the previous seminar, mitral valve disease and dilated cardiomyopathies are the most common heart conditions in dogs. But since we are discussing cats, so I'll start with hypertrophic cardiomyopathy. So HCM, which is a short form, uh, some of you who are practicing cardiology must have encountered this because this is a very, very common heart condition in cats. I personally have seen this in a lot of Persian cats because the Persian cats, they are quite common in our country. Uh, this disease is characterized by the thickening of the walls of the left ventricle. It's a very common cardiac condition in cats, and the clinical symptoms, they start usually within 2 to 4 years of age. And young cats are mostly affected. Male cats have a more higher predisposition, and they are more severely affected. This is just to show you all, how some of the HCM cats, they would be presented to you at your practice. They would be dyspneic, they would be having a very fast respiratory rate. When they come to you, if you take an X-ray, it would be something like this in many of those cases. So here, you can appreciate that in the lateral view here, the cardiac silhouette is not very clearly visible because there is a lot of pulmonary edema in the cranial and the caudal lung lobes. So there is a lot of this interstitial alveolar pattern, which we all can appreciate in this lateral view, as well as in the ventrodorsal view. Uh, the pulmonary edema, it comes secondary to the congestive left heart failure in all these HCM cases. And when they come, if you don't give immediate attention, if you don't start the treatment immediately, then it can become a very fatal heart condition. But at the same time, let me tell you all that if you are very prompt in your treatment and the way you handle when these cases in congestive heart failure of cats, they come to your place, they do show good recovery as well. We will be talking about the treatment protocols later on in the presentation. This is just to give you a brief idea of how they would be represented, when they come to you. So this X-ray basically shows pulmonary edema. This shows cardiac silhouette not being very clear. This is another cat. This is a different cat. Uh, this was a cat again with HCM, and this, when it came to us again, was having tachypnea, dyspnea, and we did the auscultation. There were crackles which could have been, which were heard. Then the X-ray again, showed interstitial alveolar pattern, as you can all appreciate in this X-ray as well. The cardiogenic pulmonary edema, which is quite evident in this. The vertebral heart score is a good method to evaluate the heart size in cats as well. So in this particular cat, Muffin, the vertebral heart score came out to be 10.1, right? So the vertebral heart score in cats, the normal vertebral heart score is 6.9 to 8.1. In this, it was 10.1, which would mean severe cardiomegaly. this is Oreo. This is the first cat after treatment. So Oreo came to us in this condition with severe pulmonary edema, and then we admitted this patient. And after treatment, after 3 days of admission, the X-ray looked somewhere close to this. So as you all can appreciate, the lungs, they are more clear in this. The pulmonary edema that has gone. We gave a lot of diuretics. We gave a lot of oxygen, and this cat recovered beautifully and is still doing very well. Is the maintenance therapy is going on, and this cat is doing very well. This I'll be showing you a video clip of how HCM would look when you do an echocardiography. So in this, you can appreciate one thing, where my cursor is on the screen is the left atrium, and this is the left ventricle. So you all can appreciate how thickened the walls of the left ventricle are. So, I'll just pause this clip once to give you all an idea. So in this, if you can carefully follow my cursor, this is the left atrium. This is the left ventricle, which is barely visible because the walls of the left ventricle, they are highly thickened. This is the posterior or the free wall of the left ventricle. This is the interventricular septal wall. So the left ventricle is severely hypertrophied in this cat. This is the right atrium. This is the right ventricle. I'll play this again. Just observe and watch this carefully, and you'll be able to make out the left ventricular hypertrophy and the thickened left ventricular walls in this. Echo loop sometimes may not be very clear because when these cats come to us, they are in severe dyspnea and tachypnea, and you have to be very, very quick in doing the diagnostic testing. Otherwise, under stress, they can collapse on the table. So, this is a very, very quick, this is a kind of a thoracic fast scan, which we have to do. Because otherwise, if you give it a lot of time on the table, and if the cat is in stress, a lot of them actually can collapse. This is something, which we as veterinarians have to educate the client also about the severity of this condition. Right. So the thickened left ventricular walls, this is clearly evident in this. So hypertrophic cardiomyopathy is basically a genetic condition. It is because of the genetics, this condition is caused in the cats. The various breeds which are affected are Maine Coon cats, American Shorthairs, British Shorthairs, Norwegian Forest cats, Persians, Ragdolls. Some of the domestic cats also seem to have this predisposition for HCM. But as I said, personally, I have seen them in a lot of Persians because they are very, very popular in our country. On physical examination, you would hear a systolic murmur in about 60 to 70% of all HCM cases. Why the systolic murmur? We discussed this in the last seminar, but for those of you who missed that, let me tell you that the systolic murmur here in the HCM cases, we call them as SAM murmurs. That is mostly because of the systolic anterior motion of the mitral valve. So the anterior mitral valve leaflet that comes in contact with the IV septum in the left ventricle, and that creates a turbulent sound, which is the reason for the murmur in HCM cases. Gallop heart sounds you would hear because HCM is a diastolic heart failure. It's a diastolic heart problem. So the walls of the left ventricle, they are going to become stiff in this. And as a result, in the relaxation phase of the heart, the blood which is coming into the left ventricle hits onto the stiffened walls of the left ventricle, and that creates this gallop heart sound. Cardiac arrhythmias we see in up to 25% of the cases. And the other symptoms, as I had just mentioned, dyspnea, tachypnea, they would be having great difficulty in breathing. There would be open mouth breathing pattern. In some of these cases where there is pleural fluid in the chest, there would be muffled heart sounds. And in a lot of these cases, sometimes thromboembolism also develops. The thrombus develops because the blood is staying for a longer period within the heart. Because of the stasis of blood within the heart, the chances of a thromboembolism develop. Clinical signs would be cardiac murmurs, gallop rhythm, dyspnea. When there is pulmonary edema, you will hear the crackles. When there are pleural effusions, you would hear muffled heart sounds. There can be arrhythmias. There can be syncope, which is a short period of fainting, and that happens because of the lack of oxygenation in the tissues and to the brain. Aortic thrombosis, which is called FATE, which is feline aortic thromboembolism. That, as I said, because of the stasis of blood, develops in some of these cases, and which is a highly fatal event. So HCM echocardiographic features. Echocardiography, my dear friends, would be the gold standard to diagnose hypertrophic cardiomyopathy, because we are primarily looking at the wall thickness of the left ventricle. That would not show up in the X-ray, that would not show up on the ECG, that would not show up on the cardiac biomarkers test. So echocardiography, one has to have, or one has to refer it for an echocardiography in order to diagnose hypertrophic cardiomyopathy. In this, the main feature is that the left ventricle wall thickness becomes more than 6 mm. So that is the gold standard to detect HCM in cats. The left ventricular wall thickness will be more than 6 mm. There is a gray zone, in which if it is between 5 and 6 mm, that becomes a gray zone where you may suspect HCM, and it may or may not be HCM. But if it is more than 6 mm, it is almost confirmatory for that. There would be two conditions which I will tell you, which you will have to rule out to diagnose that it is a primary HCM. Even if it is more than 6 mm, the left ventricular wall thickness, even if the LV wall thickness is more than 6 mm, and those two conditions are there, then it can be the left ventricle thickened walls may be secondary to those two conditions, which are systemic hypertension and which is hyperthyroidism. So these two conditions we'll have to exclude. HCM, as I said, is a diastolic heart problem. The systolic functions and the contractility of the heart is absolutely fine in all HCM cases. There would be a normal to a mildly decreased end diastolic dimension of the left ventricle. So sometimes, in fact, from the practical point of view of many times, when I do echocardiography for HCM cats, the left ventricle lumen, it appears to be small, because this many times leads to a hypovolumic heart, and the increased thickness of the left ventricular walls can lead to the left ventricular and diastolic diameter looking to be very decreased in a lot of these cases. As the disease progresses, left atrial dilatation will keep on increasing, and in a lot of these cases, left atrial dilatation is also a characteristic feature, specifically as we move to the advanced stage of the disease. HCM is a diastolic impairment with delayed relaxation pattern and decreased tissue velocity imaging of the E wave. So for this, when we talk about echocardiography, there is a measurement of E wave on the TVI. TVI is the tissue velocity imaging. So that E wave measurement tells you about the diastolic dysfunction and the delayed relaxation. SAM of the mitral valve, it may be present in a lot of these cases. As the systolic anterior motion of the mitral valve happens, it leads to an outflow obstruction in the left ventricular outflow tract, and that creates the murmur. and that causes more hypertrophy of the left ventricle. HCM, there can be various types of HCM. There can be just papillary muscle thickening. There can be a focal hypertrophy. There can be a concentric hypertrophy, which is the most common form of HCM, in which there is generalized thickness of the left ventricle. There can be SAM, as I said, systolic anterior motion, which will cause a left ventricular outflow tract obstruction. And that is another form of HCM. So in this diagram, you can appreciate, the various forms, like where the cursor is here, only the IV septum is thickened. The left ventricular free wall here appears to be normal. Over here in this diagram, the left ventricular free wall is thickened, whereas the IV septum, that appears to be normal. Over here in this diagram, only the papillary muscles, they seem to be thickened, and we would call it a papillary muscle thickening. Over here again, the papillary muscles, they are thickened. It is another form of focal hypertrophy, as you can say. Over here, it is a concentric hypertrophy because the left ventricle is thickened throughout. It is diffusely thickened. So as I mentioned, 6 to 10 mm thickness of the left ventricle will be confirmatory for HCM or HOCM. HOCM is a short form of hypertrophic obstructive cardiomyopathy. So hypertrophic obstructive cardiomyopathy, or HOCM, is named because when SAM develops, because of SAM, the left ventricular outflow tract obstruction develops, and that we would call it as a HOCM. 3 to 5 mm or 3 to 5.5 mm is a normal. It happens in normal cases. It happens in restrictive cardiomyopathies where the wall thickness is generally not affected. In dilated cardiomyopathies, because of the overuse of the cardiac muscles and the cardiac cells, the myocytes, the walls of the left ventricle, they become thin. So it's thin walled, as we call it, and the wall thickness of left ventricle can vary between 1.5 to 3.5 mm. So these are all important points to consider when you are doing echocardiography to diagnose various heart conditions in cats. As I had earlier mentioned, the differentials for left ventricular hypertrophy are namely three. So whenever the walls of the left ventricle, they are thickened, it can be either of these three conditions. It can be HCM. It can also happen in hyperthyroidism. It can also happen in systemic hypertension. So your gold standard to diagnose hypertrophic cardiomyopathy or HCM would be thickened left ventricular walls more than 6 mm size, and normal thyroid functions, and no systemic hypertension, right? So you have to always exclude hyperthyroidism and systemic hypertension, because in these conditions also the left ventricular walls become thickened. So as we discussed, for diagnosis of cats with left ventricular hypertrophy, you have to measure the arterial blood pressure, you have to evaluate the thyroid function, you have to interpret the echocardiogram properly, you have to carefully observe whether the left atrium is small or large. For those of you who are doing echocardiographies, let me tell you that the left atrium in cats, I generally evaluate the size by two methods. One is a commonly used method, which is left atrium to aorta ratio, which should be less than or equal to 1.5. And the other method is to measure a 2D dimension, two-dimensional measurement of the diameter of left atrium in diastole. So when the left atrium is completely enlarged at end diastole, you measure the diameter, you take a 2D measurement, and the cutoff is less than 16 mm. 16 mm is the cutoff. If it is more than that, would indicate left atrial enlargement. And this is a very valuable tool because left atrium to aorta ratio is very commonly used, but the 2D measurement of left atrium in end diastole, a lot of us practicing or doing echocardiographies we don't do, but 16 mm is a good cutoff, in end diastole, when you're doing 2D measurement of the left atrium. So as we said earlier, you have to exclude systemic hypertension, you have to exclude hyperthyroidism. And if we talk about screening for HCM, male cats, it should be over 2 years. Female cats, after they are 3 to 4 years, we should screen. And if the cats are examined earlier, they should be rechecked for this disease, specifically if they have the breed predisposition. This is just a diagrammatic representation of the 3 common heart conditions in cats. DCM, as we all know, it's a systolic dysfunction. It's a contractile failure of the left heart. It's a pumping failure. In DCM, you would have, in a lot of cases, when they are in the advanced stage, you would have pleural effusions, you would have pulmonary edema because of left-sided congestive heart failure. When we are talking about HCM or HOCM and RCM, these are diastolic dysfunctions of the heart, and they will cause characteristic signs of diastolic heart failure. And in diastolic heart failure, again, we can have pleural effusions, we can have pulmonary edema. And on the other hand, for cardiac structure and phenotype, in dilated cardiomyopathy, you would have volume overload of all the chambers or of the left heart. You would have sometimes taurine deficiency dilated cardiomyopathy. So in cats with DCM, specifically those who are on home diets, the taurine levels, they should definitely be measured. In fact, in all cases of dilated cardiomyopathy in cats, if we have the option available of measuring taurine, we should, because taurine deficiency DCM is reversible, and with supplementation of taurine, it reverses and the prognosis is good. When the size of the left ventricle chamber is normal or small, we can suspect HCM, HOCM, RCM. And in cases of normal, again, in cases of normal, again, you have to think, when there is a gray zone or suspicion, you have to think about other problems which can cause changes in the heart, like hyperthyroidism, systemic hypertension. There can be aging changes, there can be dynamic left ventricular outflow tract obstruction, just to name a few. The measurements for HCM, I generally do the M mode measurements, but that is more from the reporting purpose, because at my practice, I rely more on the 2D measurements. So if this is the left ventricle, the IV septal wall and the left ventricle free wall, you have to measure this in 2D. So, you freeze the image, you scroll through the echo loop, and you measure the IV septal thickness and the left ventricular free wall thickness at different areas. And as we had mentioned earlier, as I mentioned earlier, the thickness more than 6 mm is characteristic for HCM. This is a short axis view, and again in this as well, the IV septal thickness and the left ventricle free wall thickness you all can measure to diagnose cases of HCM. This is a HCM staging which is followed at the Munich University, and I've seen that it works, because when we do the staging and when we tell the clients that whether it is a mild form of HCM or a moderate or a severe, the clarity regarding the prognosis becomes important here. And if we communicate things properly to the client, then in cases of a fatal event when the cat dies, it would not come up as a shock to the client. So mild cases of HCM as per this staging is 6 to 6.5 mm. When the left ventricular free wall or the IV septum thickness in diastole. So these are general diastolic measurements which we have to rely on. 6 to 6.5 mm would be labeled as a mild hypertrophic cardiomyopathy. 6.5 to 7 mm would be labeled as a moderate HCM, whereas a severe form of hypertrophic cardiomyopathy would mean that the left ventricular free wall and IV septal thickness and diastole would be more than 7 mm. The X-rays which I showed you earlier of the two cats, Oreo and Muffin, when they came to me in condition of congestive heart failure, where there was pulmonary edema, I did the quick echo, and their wall thickness was almost more than 8 to 9 mm. So that was a very, very severe form of HCM. Fortunately, both of them, they showed great recovery, but I had to admit them. And after almost 3-4 days of admission, the symptoms and the clinical signs, they reversed. Unfortunately, they are doing well as of now. So this is a post-mortem slide, of SAM. SAM, as the name goes, is systolic anterior motion of the mitral valve. So here, if you carefully observe the walls of the left ventricle, they are severely thickened. This is the left ventricle internal lumen, which you all can see. These are the papillary muscles. This is the mitral valve. So this is the mitral valve posterior leaflet. This is the mitral valve anterior leaflet. In SAM, what is happening is that this anterior leaflet of the mitral valve, that is coming in contact with the IV septum. And as a result of this contact of the anterior mitral valve leaflet and the IV septum, there is a obstruction in the left ventricular outflow tract. So, if we carefully observe the left atrium, it is going to contract and it is going to push blood into the left ventricle. Now from the left ventricle, the aortic valve opens, and this is the left ventricular outflow tract. So from the left ventricle, the blood is going into the aorta, which is here. Now the SAM, which is systemic, which is systolic anterior motion of the mitral valve, this is causing an obstruction here. So these are cases which we also call as HOCM, hypertrophic obstructive cardiomyopathy. These are some other echo loops of cases of HCM. This, as you all can appreciate here, the left ventricular walls, they are thickened. Even before the measurement, many times, you just have a subjective evaluation of the left ventricles, and that gives you a good idea. I mean, immediately you see, and I mean, it comes to your mind that the left ventricular walls, they are thickened, and you automatically come to a semi-diagnosis, and then you later do your measurements. You rule out systemic hypertension, you rule out hyperthyroidism, and then you come to a diagnosis of HCM. These are some of the other examples. As you all can appreciate in this is a focal hypertrophy. So these are the papillary muscles on the screen where my arrow is. These are the papillary muscles, and this is a focal hypertrophy of the papillary muscle. So this papillary muscle, you can appreciate this is thickened. This again is another example of HCM. This is a mild HCM where the walls, they are thickened. Mild HCM, according to the staging which is followed by Munich University, would mean that the left ventricular wall or the IV septum wall in end diastole would be between 6 to 6.5 mm. So when you measure this, it would be that much. So we are done with HCM. I hope you all understood. If there is any doubt or if there are any questions at the end of this session, I would be more than happy to answer those. We come to the second most cardiac condition in cats, which is called restrictive cardiomyopathy. This is again a diastolic dysfunction. HCM is also a diastolic dysfunction. Restrictive cardiomyopathy, which we call RCM, is also a diastolic dysfunction. Many of these cats would come up to you like this, in which there would be ascites, there would be severe dyspnea, tachypnea, and there would be open mouth breathing. So when these cases come, that becomes an immediate emergency. This is just a video loop to give you all an idea of how restrictive cardiomyopathy or HCM would look on the echo. Hypertrophic cardiomyopathy, we all saw that echo loop. This is RCM. So the characteristic here, if you just have a subjective evaluation, I think you all can appreciate the severe enlargement or dilatation of this left atrium and the right atrium. So RCM would have this characteristic finding of biatrial dilatation. The left atrium as well as the right atrium, they would be severely dilated. Right. So if you carefully observe, the contractility is good in this loop, but both the atria, they are severely enlarged. The left ventricle walls also on the subjective evaluation, they look okay. There is no wall hypertrophy, as you all can appreciate, but the characteristic first finding which you all can appreciate would be the dilatation of both atria. And in my personal experience, I have seen that the left atrium is more dilated than the right atrium. So RCM, as I mentioned, is the second most common form of cardiomyopathy in cats. Its classical feature is that it's a diastolic problem caused by increased stiffness of the myocardial walls. And in this, the ventricular walls are generally not thickened. 95% of the cases, they would not be thickened, but sometimes a small amount of left ventricular hypertrophy in the advanced cases can happen. But generally, the left ventricular walls would not be thickened. Contractility will be good. The systolic functions, they would be very good. But the characteristic finding on the echo would be that the both atria would be enlarged. Severe dilatation of left atrium and right atrium. So this is again a quick recap. Both atria, they would be enlarged. The ventricles, they would be neither hypertrophied nor dilated. Diagnosis, it would be confirmed by tissue Doppler imaging. Even for those of you who are not doing echocardiographies, it is still important to know this fact that the diagnosis of RCM would be either through a tissue Doppler imaging, or if that is not available, you have to use the mitral inflow profile. These are some of the echo features of RCM. There would be normal left ventricular wall thickness, as I said, in most of these cases. The contractility or the systolic functions of the heart would be absolutely normal. Both the atria, they would be severely dilated. There would be a restrictive filling pattern of mitral inflow profile. So, for those of us who are doing echocardiographies, because that is the gold standard test to diagnose RCM in cats, there would be a restrictive filling pattern of the mitral inflow profile. The E wave to A wave ratio would be greater than 2, and there would be a very short deceleration time. So the classical finding which I use is the EA ratio, and in cases of restrictive filling pattern, it is more than 2. Restrictive tissue velocity imaging pattern, for those of us who have this feature in the echo machines, is also a very good feature by which we detect RCM. So in this, the E wave velocity has to be less than 2.5 centimeters per second. In a lot of these cases, there would be a large fibrotic bridging band or scar of the left ventricle. So sometimes this hyperechoic band or scar in the left ventricle, we generally come across in advanced cases of RCM. That happens because of the death of myocytes, because of the increased stiffness of the left ventricles. As I mentioned, that left ventricular hypertrophy is very rare, but in the very advanced cases, you would come across sometimes this occasional mild left ventricular hypertrophy. It is always accompanied by severe left atrial dilatation. These are some of the transmitral inflow patterns. Well, I have to include this slide because RCM diagnosis, one has to have the echocardiography done. I mean, if you are not doing it, you can always refer, and it's always good for even those who are not practicing echocardiographies. It's good to know this, because when the report comes to you, you at least know that it is correctly done. So in this, there are 4 different patterns, as you all can see. There's a normal pattern in which the E and A wave would appear like this. Then in the grade 1 diastolic dysfunction, the E wave would become short, the A wave would become tall. Then there is a pseudo normalization as the left ventricular end diastolic pressure is increasing with the advancement of the diastolic dysfunction and with the advancement of the relaxation abnormalities of the left heart. The left ventricular end diastolic pressure, it is constantly increasing, and there comes a time when there is pseudo normalization in which the E and A wave, they appear normal but they are not normal. So that is pseudo normalization. Then as the diastolic dysfunction advances, the E wave would further become tall and the A wave would become very, very short. And the EA ratio, when we calculate, would be more than 2. And that is restrictive mitral inflow pattern. And that is a characteristic for diagnosis of RCM. If not mitral inflow pattern, then we can use tissue Doppler imaging, in which there is a TDI icon on the ultrasound machines. You have to turn on that TDI icon, and you have to then press the pulse wave Doppler. You have to bring your pulse wave Doppler sample gate over here, just above the mitral valve, on the interventricular septum. And then you turn on the pulse wave Doppler mode, you will see this kind of a graph in which there is a systolic S wave and there is a negative E wave and A wave. You measure the E wave velocity here, and less than 2.5 centimeters per second would mean relaxation abnormality and would mean RCM. You have to combine it with the other RCM features of biatrial dilatation, and that would be a gold standard to detect RCM in cats. This is again, this is again a echo loop of the systolic wave, the E wave, and the A wave. This is in the tissue Doppler imaging, and in this the E wave becomes short, and when you measure it is less than 2.5 centimeters per second. These are echo loop images of how the RCM would look and appear on the echocardiography. As you all can appreciate in this, both the atria, the left atrium here and the right atrium here, they are severely dilated. Here again, the left atrium is huge and the right atrium is also dilated. The walls, they are not hypertrophied. The contractility, as I had shown you all in the video loop, contractility would be normal in this. These are some of the other loops. As you all can appreciate, the biatrial dilatation and the left ventricle walls, they are absolutely normal. The contractility, when we check, it would again be normal in these cases. The only abnormal thing would be a diastolic dysfunction, which we would diagnose either through a mitral inflow profile pattern, in which you would have a restrictive physiology, restrictive mitral inflow pattern, EA ratio to be more than 2, or when you turn on the tissue Doppler imaging and you measure the E wave velocity, it would be less than 2.5 centimeters per second. This is the zoomed image of the same systolic S wave, the E wave, A wave. This is a tissue Doppler velocity imaging. I hope RCM was clear. Now we come to feline dilated cardiomyopathy. Feline dilated cardiomyopathy, the basic concept is similar as in cases of dogs and cats, that this is a systolic myocardial heart failure. The left ventricle in all these cases of DCM in cats is not able to pump out the blood properly. It is not able to contract properly. These are X-ray images of a cat called Kubla, which had come to me 4-5 years ago. And in this, as you all can see, the dilatation of the heart. Again, I would request you all that when you do the chest X-rays, you do this VHS measurement, vertebral heart score measurement is a valuable diagnostic tool. So in this, you all can appreciate the dilatation of the heart, generalized cardiomegaly. Over here, you can also appreciate the enlargement of the left atrium. So the left atrium is here. You can see the arrow on the screen. This is the left atrium, and this is also dilated. Otherwise, the mainstem bronchus generally in a normal heart would come like this. It would, slant like this. Whereas in cases of DCM, where the left atrium is enlarged, or in cases of even HCM or RCM, wherever the left atrium dilatation is there, the mainstem bronchus, it would come like this. It would go up because of the dilated left atrium. The VHS in this case, let me measure. So it was close to almost 10 in this case. Normal, as I had mentioned, in cats, the normal vertebral heart score is 6.9 to 8.1, whereas in dogs, it is 8.7 to 10.7. There are some breed variations. If we talk about dogs, there are some breed variations where in cases of beagles, sometimes cocker spaniels, sometimes pugs, the vertebral heart score may be 11 or 11.5, and the heart functioning is normal. So there may be some variations in dogs, not so much specifically in cats, but overall vertebral heart score is a good indicator of heart enlargement. And then, after this, once you see the enlarged heart, you of course have to move on to other diagnostics. This is an echo loop of the same cat. The X-ray images I showed you were of this cat. Then I had to do an echocardiography, and it was like this. So in this, this is, by the way, after treatment. All these echo loops are after treatment of, with pimobendan and with diuretics. So this is after treatment, but in this as well, you all can appreciate that the left atrium is severely dilated and there is a contractile dysfunction. The heart is not able to contract properly as it should. A normally contracting heart would be much better, in terms of the contractile functions, but in this, the contractility is affected. Then we turned on the color Doppler, and you all can appreciate in this, there is eccentrically directed flow within the left atrium. So there is mitral valve regurgitation, but mitral valve regurgitation, my dear friends, and this is secondary to the systolic dysfunction. So in all cases of systolic heart failure, the mitral valve regurgitation would be secondary to the systolic myocardial heart failure, right? So in this, there would be eccentrically directed jet. If it's a primary mitral valve disease, then the mitral valve regurgitant jet would be more uniformly spread within the left atrium. But here it is eccentrically directed, in a stream. So these are the right-sided long axis views. We have some echo loops of the left apical four-chamber views. This is again the same cat, and as you all can see, the contractility is affected here. The heart is not able to contract properly. So this is a classical case of dilated cardiomyopathy in the cat. I did measure the taurine levels and they were normal. This was a case of a primary myocardial heart failure. So feline myocardial heart failure, when you do the echocardiography, you would have to look at the left ventricular end diastolic and end systolic measurements. The gold standard for diagnosis of DCM in cats would mean that left ventricular end diastole measurement would be more than 20 mm and left ventricular end systolic measurement would be more than 12 mm, and the fractional shortening would be less than 25%. So when you put on the M mode, the time motion mode echocardiography, the fractional shortening would be less than 25%. But let me tell you, even before you do the measurements and the calculations, you just have a subjective view properly. I mean, don't do the measurements straight away. You just look at the video loop, you just see the contractility, and that will give you a very good idea that this is probably going to be dilated cardiomyopathy. So these are some of the images of DCM loops. There is in this, as you all can appreciate, severe left ventricular and right heart volume overload. So we use the terminology when there is enlargement, we call it a volume overload, right? Because it is overloaded with the extra volume of the blood. This is the right long axis view. Again, in this, there is generalized volume overload of all chambers. This is another loop. Again, severe dilatation, severe volume overload of all the four chambers. This is a loop where you all can see the thrombus. So this is a short axis view. This is a aorta here. This is the left atrium here. There is severe left atrial dilatation, as all you all can appreciate, and there is a big thrombus in the left atrium. So this thrombus develops in a lot of these cases of advanced DCM or advanced HCM or RCM. Because of the stasis of blood, it predisposes them for the thrombus formation. And then, once this is formed, and if it gets lodged into the abdominal aorta, it can be a very, very fatal condition. Now coming to ARVC, which is called arrhythmogenic right ventricular cardiomyopathy, which is also called boxer cardiomyopathy when we talk about dogs. So this is for you all to know, this is similar to the boxer cardiomyopathy. In this, the fatty infiltrates, they replace the myocytes. Variable degrees of arrhythmias, they can be there. There can be a right bundle branch block. There can be atrial fibrillation. There would be very commonly, we see the VPCs, ventricular premature contractions. There can be APCs, which we call the supraventricular premature beats. There can be atrioventricular conduction blocks. And if you do the echocardiography in these cats, there would be poor systolic functions, poor contractile functions of the right ventricle, and that would cause severe right ventricular volume overload. So this is a disease of the right heart, and this is characterized by severe right ventricular volume overload, right ventricular myocardial heart failure. There is reduced systolic function. So this is a systolic dysfunction. There would be a severe right atrial dilatation. and in some of these cases there can be a mild to normal, that either the left atrial dilatation may not be there, or there can be a mild left atrial dilatation. To sum it up, it would be ARVC in cats is a very rare condition, but in any cat, when you see right atrium and right ventricular volume overload, and when you suspect that the contractility of the right side of the heart is affected, then ARVC should be on the list of your differentials. To sum it up again, echocardiography is the most useful test to differentiate feline cardiomyopathies. To detect all these cardiac diseases in cats, you either have to perform the echocardiography or you refer it to a place where it is done. And screening for HCM, it's a very common heart condition in cats, specifically, where there are predispositions of certain breeds like Persians that would need experience, that would need skill, that would need proper measurements and calculations. So the measurements you have to very carefully do, because my suggestion would be, to do the measurements, but also you have to correlate it with a lot of other things. Just doing the measurements can sometimes mislead you to a diagnosis. So you have to carefully do the subjective evaluation. As I had said, a bird's eye view of carefully observing what is going on within the heart, carefully checking the X-rays, carefully correlating it with the clinical signs, ruling out things like systemic hypertension, hyperthyroidism, taurine deficiency. So these are some of the things, which you have to keep in your mind when you are trying to diagnose feline heart diseases. So these are some of the indications and suggestions of the cardiomyopathies, and as to why we should perform an echocardiography in cat. Well, whenever you hear a murmur or a gallop rhythm, or there is a breathing difficulty, if there is dyspnea, tachypnea, if the heart rate and rhythm is irregular, that would be indications, to do further diagnostics. You do the X-rays, you do the echocardiographies. Where the rhythm is irregular, you do the ECGs. You combine all the results, you combine and correlate with the clinical signs, and then you come to a diagnosis, and then proper treatment can be initiated. There is a thing about biomarkers. Again, when there is a dyspneic cat, it can be a primary respiratory problem, or it can be a dyspnea secondary to a cardiogenic problem. So here, this NT-proBNP cardiac biomarker, which is available in our country, you have these IDEX, you have the VCheck NT-proBNP feline specific kits. I use these at my practice. And let's say, I'll give you an example. So let's say a cat comes with dyspnea, and uh, the you do the auscultation, and there is a doubt in your mind that whether this is respiratory or whether this is cardiac. Well, my suggestion to all of you would be that, if you don't have the diagnostics, you can keep these kits handy, or you can uh, refer for the analysis of NT-proBNP levels. If it is more than 100, you can suspect cardiomyopathies. Let's say in that cat where you are suspecting a feline cardiomyopathy, it comes out to be, let's say, 50. Then you can be pretty sure that this may not be cardiogenic. This is more likely to be respiratory. On the other hand, there is a cutoff of 250 to 300 picomoles per liter of this NT-proBNP value. If it is that much, then it is almost certain to be a congestive heart failure, because in congestive heart failure in cats, this value shoots up to more than 250 to 300. So this value, if it is less than 100, you can highly likely suspect it to be a respiratory disease and not a cardiogenic disease. If it is more than 100, let's say 100 to 150, you can suspect that this is a cardiogenic disease. And in many of these cases where it is between 100 to 150, those are cases of asymptomatic cardiac disease in cats. But where it is more than 250 or 300, you can be pretty certain that it is likely congestive heart failure because of the underlying cardiac disease. So these are just some of the studies, as I have already discussed, that more than 100 would be highly effective for us to suspect that this is a subclinical cardiomyopathy. This has high sensitivity and high specificity. There was another study, as I had just mentioned in the previous slide, that the dyspneic cats with plasma NT-proBNP value above 265 picomoles per liter were likely to have heart failure. And again, the sensitivity and specificity, as you all can see, is very good. Cats with congestive heart failure had a median NT-proBNP value of 754, and 90% of the values exceeded 300. So 300 is a good cutoff, for us to suspect that this is likely congestive heart failure. So a higher NT-proBNP value should increase the confidence in congestive heart failure diagnosis. So this is a valuable cardiac biomarker, and this is now available. So I'm just trying to create awareness amongst all of you that you can start using this. This is a valuable and a highly specific and sensitive diagnostic tool. Where we don't have the facility of echocardiographies, you can use this. Though of course, I'm not denying that echocardiography will be the gold standard to detect a lot of these cardiomyopathies, but as a first-hand information, this NT-proBNP value would be a very very valuable diagnostic tool. Echocardiography in a cat, well, you have to use a 7 megahertz transducer. Cats which are dyspneic, which come to us with open mouth breathing and severe respiratory distress, you have to do a very quick echo, because if you spend a lot of time, the cat may just die on the table. So you have to just try to do a very quick subjective echocardiography. You have to look for the left atrium size, you have to look quickly for the effusions, and then you communicate the same to the owner. If there are effusions, if it is a severe dilatation of the chambers, you communicate to the owner about the prognosis. Cat owners, they can be highly emotional, and this communication is very valuable. You have to set up in their minds about the severity of the disease and the prognosis. There are some feline sedation protocols, because sometimes the severely dyspneic cat who is under a lot of stress because of being in the clinic and because of other people being around, there are high chances of this cat with CHF dying on the table. So if you want to give some sedation, the safe ones in the bottommost line, where there is cat with the congestive heart failure, because this I have personally used butorphanol and midazolam. This combination works well. This is very safe. Acepromazine, again, you can use in the uncooperative cat, but butorphanol and midazolam combination I have used personally, and this is safe enough. There is another thing where we can use gabapentin. These gabapentin tablets which come. So if let's say if the owner calls you and tells you that my cat is very very hyper, and for examination, the cat is not going to allow you, and in stress, there can be fatal events, and if the owner is very concerned, you can tell them that they can use gabapentin at the dose of 10 to 20 mg per kg. Gabapentin tablets are available, and they can give the tablet 1 day prior to them bringing the cat to you, and 2 hours before they come to you. So let's say if a cat needs to come to me tomorrow, I'll tell the client that you give gabapentin at the dose of 10 to 20 mg per kg gabapentin tablet today, and then you give it again tomorrow, 2 hours before you bring the cat to me, and it works fantastically well. When this particular cat on which you've given gabapentin comes to you, it would be absolutely calm, and you can do your examination properly, and it is safe enough to be used in cases where the heart is affected. Okay, so now we've discussed about the diagnosis of various cardiomyopathies in felines. We've talked about hypertrophic cardiomyopathy, restrictive cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy. Now I'll talk about the treatments. When you're talking about the treatments, you have to consider the genetics involved, whether there has been any syncope or not, whether there have been any tachyarrhythmias or not, whether there has been a history of myocardial failure or not, whether the chambers they are dilated or not, whether the walls they are thickened or not, whether there is any kind of scarring on any of the heart walls, whether there is any kind of hypoechoic structure which you see on the left ventricular wall. So you have to consider all these, and then you come to a treatment protocol. When we talk about treatment protocols for feline cardiomyopathies, the most commonly used drugs would be these. So in diuretics, we either use furosemide or more recently torsemide. We use beta blockers in cases where the heart rate is very high, or where there is systolic anterior motion of mitral valve is present, where there is hypertrophic obstructive cardiomyopathy present. So we can think about atenolol. We can think about calcium channel blockers to slow down the heart rate, which is diltiazem, which is commonly used. We use antiplatelet medications to prevent the clots and thrombus to form, which is clopidogrel. It's a new age drug, and this as a prophylactic for thromboembolic events, we use it quite a lot. It is very safe. We use ACE inhibitors. Benazepril is a very commonly used ACE inhibitor. It has minimum uh, renal side effects, and this is a commonly used ACE inhibitor. We use oxygen therapy where there is congestive heart failure. We use wherever there are pleural effusions, we will do the tapping, we will remove the fluid. So these are some of the commonly used drugs for treatment of cardiac diseases in cats, but which drug to use when would depend on a lot of factors, on the level of dyspnea, on whether there are pleural effusions or not, whether there is pulmonary edema or not. You have to consider the heart rate. So there are lots of things which you have to consider to choose one of these drugs or a combination of these therapies. So this we've discussed. Insights for therapy would be a malignant phenotype, would be whether the heart walls are thickened or they are dilated, whether there is left atrial enlargement or not, whether there is SAM or left ventricular outflow tract obstruction or not, whether there is infarction, syncope, diastolic dysfunction, whether there is a prothrombic state or not. And management options, as I had mentioned, would be that you either use beta blockers, calcium channel blockers, ACE inhibitors, diuretics, or whether you don't need to start the treatment. Talking about diltiazem, it will improve the early diastolic relaxation. It does not have any effect on ventricular compliance. It will reduce the heart rate, and there have been various studies on the use of diltiazem in cats with congestive heart failure, or in the or cats which are in the preclinical stage. And as of now, there is no convincing proof that early diltiazem delays the onset of CHF. Beta blockers, a commonly used beta blocker is atenolol. What it will do will reduce the heart rate. It will prevent tachycardia. It will reduce the systolic anterior motion of the mitral valve, and that is important in cases of SAM, because SAM will cause more and more hypertrophy of the left ventricle, right? So this drug, it does not improve the diastolic function directly, but we are treating the symptoms. It is going to slow down the heart rate. It is going to treat the SAM. It is going to slow down the progress of left ventricular hypertrophy. And this, you use it at the dose rate of 6.25 to 12.5 mg per cat, once to twice a day. Again, in the studies, there has been no convincing proof that early atenolol will delay the onset of CHF. Treatment of SAM, as I had just mentioned, atenolol can be used, but very personally speaking, from my personal experience, I generally don't use atenolol. Only if the heart rate is going to be very, very high constantly and consistently. If the heart rate is going to be higher, let's say, than 220 to 30 per minute, in those cases, you have to slow down the heart rate and you use atenolol. Because if you don't, then this fast heart rate with presence of SAM is going to cause more and more hypertrophy of the left ventricle at a very fast pace. So whether to use atenolol or not, consider the heart rate at rest. So you tell the owners how to check it, and if it is consistently going above 220 per minute, only then think about uh, rate control medicines, which you can use atenolol, but heart rate here is important. This is another study in which it was to know whether the effect of ACE inhibitors and whether no treatment uh, would be needed in cats with asymptomatic HCM. So there is HCM, the walls are thickened. Let's say there is a very mild HCM and there are no symptoms. So whether to give the treatment or not. So as per this study, which was done in Maine Coon cats, there was no difference between cats treated with ACE inhibitors and the cats which were not treated. So there was no difference in the outcome. So asymptomatic HCM, this is another study in which spironolactone was used to treat asymptomatic HCM. And again, there was no difference between spironolactone and no treatment. In fact, a lot of cats which are on spironolactone can develop these skin lesions. So spironolactone, I don't use in cats because these skin lesions can develop because of this drug. And at my practice itself, I have seen 2-3 cases where there were skin lesions after initiating spironolactone therapy. So to summarize, the evidence that medical therapy favorably alters the course of subclinical fenyl cardiomyopathy is lacking, and usually the asymptomatic cats would need no treatment. But at the same time, my suggestion would be to closely monitor the condition, to educate the owners how to check the heart rate, how to check the respiratory rate at home, because when they can do these measurements, when they can check the heart rate, respiratory rate at home, you can guide them that if it is going above a certain number, they can just bring the cat to you for further diagnostics and any treatment which we need to start. So diastolic heart failure, some of us who have seen this would mean that in diastolic heart failure there would be pulmonary edema, there can be pleural effusions, the cat would come to you in a real emergency with open mouth breathing, severe dyspnea and tachypnea, as if the cat is about to die. And trust me on this, that if you don't handle the case immediately, if you don't initiate all the diagnostics and treatment immediately, the cat just may collapse, right? So in this, if there are pleural fluids, you have to tap them. That does give them immediate relief. I generally do it from the right side. I do it ultrasound guided. I use a scalp vein. I use a 3-way stop clock, so that air doesn't go in. And once pleurocentesis is done, you have to make sure that the cat is calm also and not coming in under stress. If the cat is too stressed, then those few sedation protocols which I had showed you, you can use those so that the cat is absolutely calm, and then you can do the pleural tap. For pulmonary edema, there are three hallmarks which we have to follow here. One thing is, the first and foremost is to rapidly remove the alveolar edema. We have to use diuretics, we have to use latex injections, and using latex injection, one has to know what dose and how frequently one has to use. Because at my practice, I generally admit all these cats, and I do an aggressive diuretic therapy with very close monitoring of the vitals. You have to restore the arterial oxygen. So either you put the oxygen mask, or if you have the facility of oxygen chamber, oxygen cabin, or an incubator, that would be even better. And the third thing would be, of course, you have to stabilize the underlying condition, whether it is dilated cardiomyopathy, you start pemobendin. If it is HCM or RCM, you have to treat accordingly. So for furosemide, in all these cases where there is pulmonary edema, and let me tell you that in a lot of these cases where there is pulmonary edema, uh, would be either HCM, RCM, or DCM. It can be any of these three commonly encountered cardiac conditions in cats. And when this pulmonary edema develops, you have to be aggressive with the diuretic therapy. I generally, the first 3-4 doses, I generally give IV, and I repeat them every 1 to 2 hours. You have to, in layman terms, you have to dry the lungs, because the more longer the fluid stays in the lungs, it can lead to these fatal events of collapses. So you have to dry the lungs. You have to be aggressive with furosemide. Most likely, you should be admitting these cases, or you can at least, if you don't have the admission facility, you can at least keep them in your clinic for monitoring purpose throughout the day. And then you give aggressive diuretic therapy, you give oxygen, and trust me on this, a lot of these cases, they actually do recover. You have to communicate it to the client that it can go either way. But yes, I mean, if you do the treatment properly, in which in cases of congestive heart failure would mean good diuretic therapy, good latex therapy, and oxygenation, and management of the body temperature. So if you stick to these treatment protocols properly, a lot of them, they do show good recovery. So now the question is, can we provide effective long-term therapy? The evidence of optimal management of diastolic heart failure. We all know the importance of furosemide, but furosemide plus, whether we need to use beta blockers, calcium channel blockers, or ACE inhibitors, that is the question. Well, let me tell you that from a practical experience, from my own personal experience, in all these cases, when we talk about beta blockers and calcium channel blockers, be it atenolol or diltiazem, I personally generally don't use them unless the heart rate is very high. So if the heart rate is constantly more than, let's say, 220, 250, then you need to control the heart rate and you can think about atenolol and diltiazem. In other cases, I generally don't use beta blockers or calcium channel blockers. ACE inhibitors, yes, benazepril is a commonly used ACE inhibitor in maintenance therapy. I use this drug. ACE inhibitors, you all know, has vasodilatory effects. Vasodilation would mean that the afterload on the heart is reduced. The pressure overload within the chambers, that is reduced. So ACE inhibitors, in which personally I use benazepril a lot, it does make sense to use it in when we talk about the management of diastolic heart failure. And furosemide and ACE inhibitors, these two drugs make sense. These are some of the other studies, and in these, there was concluded that there is no evidence that cardioactive drugs be it enalapril or atenolol, whether they improve the survival outcome beyond that of furosemide alone. So here the furosemide alone was good enough. Then the treatment strategies yielded similar survival outcomes for both the entire study observation time and the first 365 days of the study. These are some of the other conclusions from the study. To summarize, drugs like atenolol, enalapril, these in combination with furosemide or furosemide alone did not make much of a difference. So you have to give importance to the usual patient care when it comes to management of CHF in cats. You have to optimize the drug therapies. There is no single standard drug therapy. You know, it depends on the clinical symptoms. It depends on the disease. Diuretics for optimal management. You know, once these cases which come in CHF to you in dying states, once you are able to stabilize them for long-term management, you think about furosemide, you think about ACE inhibitors, which is benazepril, you think about pimobendan when it comes to dilated cardiomyopathy, you think about even nutraceuticals like we have Tauretin Plus from Oriheal, carnitine, taurine. You know, you think about these nutraceuticals where you can't measure the taurine. So if you can't measure taurine, I mean, and if it is a case of DCM, then my suggestion would be to use supplements with taurine, carnitine. You know, you have to have a clear, detailed discharge planning. You have to teach the client how to check the heart rate, how to measure the respiratory rate, because those will be red flags for them, and then they can communicate and bring the cat to you in case of a increased heart rate or respiratory rate, and that will save another event of congestive heart failure to develop. So there has to be vigilant patient follow-up, and the management of patients' unique problems and identifying those also are very important. So as I said, the home monitoring for the owners, you can tell them to check the respiratory rate at rest. If it is constantly more than 45, can be a red flag. They have to bring the cat immediately to you. 15 to 30, 35 respiratory rate per minute is normal. More than 40 to 45 would be a red alert. You know, that would mean that they are either in CHF or they can develop CHF. So they need to come and see you immediately. So the respiratory rate goes up before pulmonary edema is visible on the radiographs. And as I said, the owner has to be given instructions that, you know, once this crosses this limit, then they need to see you immediately. For refractory heart failure, you have to revalidate the differentials. You have to assess the disease again. You repeat the echocardiography, radiographs, check the blood pressure again. You have to check the uh, the thyroid levels. You have to do cytologies. You have to again basically rework the whole treatment planning and diagnostic planning. So this is an important slide where it tells us about the current recommendations. In cases of HCM, if there is a mild HCM, you know, if the wall thickness is from 6 to 6.5 mm of the left ventricle and the cat is asymptomatic, it usually does not need any treatment. You can just call them again after 3 to 6 months. You can again do the evaluation. You can tell them to check the respiratory rate at home, and that should be good enough. If there is SAM, you can use atenolol, but only if the heart rate is very high. If it is more than 220, 250 per minute, only then you can think about atenolol. If there is moderate HCM, which would mean that the left ventricular wall thickness is between 6.5 to 7 mm. If there is moderate HCM and no SAM, ACE inhibitor is a question mark. My personal preference, you know, when it reaches this moderate HCM stage, you start using ACE inhibitors. I have seen it prolonging the progress to severe HCM or a CHF. Severe HCM, definitely ACE inhibitor plus furosemide. We have to be careful with atenolol and congestive heart failure. As I said, the heart rate has to be constantly be very, very high only. Then you think about using atenolol. Spironolactone, my suggestion is don't use in cats. For a diuretic, you use only Lasix, because spironolactone can get you those bad skin allergy reactions. And I've seen these happening, and it can be a disheartening event, when it happens and the owner sees it. Restrictive cardiomyopathy, there is no published study specifically designed to treat RCM. We use the standard CHF therapy. Standard CHF therapy would mean that, if there is pleural fluid, you do the pleurocentesis. If there is pulmonary edema, you use diuretics, you give oxygen. So there is the standard congestive heart failure therapy which you have to use in cases of RCM. Once the patient is stabilized, in long term, again, you can think about using furosemide and ACE inhibitors for long term management. And again, you can educate the owners to check the respiratory rate and the heart rate at home. DCM, we would add pimobendan, we would add furosemide, we would add ACE inhibitors, we would add nutraceuticals which have taurine. If the prognosis is poor if it is idiopathic form, but this is from the point of view of theory. In some of the cats, I've personally seen them to go on to live for a good 2-3 years, if they're properly managed. But the standard drugs for DCM therapy remain the same in cats as in dogs. Would mean pimobendan, would mean furosemide, would mean ACE inhibitors, would mean nutraceuticals. So furosemide, this I had shown you earlier. There is an aggressive approach where you use it at the dose of 1 to 2 mg per kg intravenous every hourly. So you admit the patient and you give boluses every 1 to 2 hours. You give a minimum of 2 to 6 doses. You keep checking the pulmonary crackles by listening to the pulmonary sounds with the stethoscope, or you repeat the radiographs to evaluate how much of the pulmonary edema is left or not. And there are some other approaches depending on the response, depending on the amount of fluid buildup. So the dose can vary from 2 to 4 mg per kg, and the frequency also depends on how much fluid is there in the lungs. So coming to the last few slides, systemic thromboembolism is a common sequelae to a lot of advanced cases of cardiac diseases in cats. In cases of HCM, RCM, DCM, a thrombus sometimes can be formed because of the stasis of blood in the cardiac chambers. When this is formed, these cats many times are presented to you with hind limb paralysis and severe pain, and the pads would be cold. There would be cold extremities. You sometimes cut the nails and there would be no supply in the no blood supply, when you cut the nails. So these are some of the common findings. And let me tell you all that if you don't attend to these cases immediately, I mean, the first 6 hours is the golden period for any treatment. That also may or may not work. Many times we have to go for euthanasia because this is a painful condition. And unfortunately, at my practice, many of these cases come to me when it has already been more than 24 hours. And those cases actually, I have seen that they never recover and we end up doing euthanasia. But if they come in the first 6 hours, then there are some therapies which we can try. And as per some of the researches, there has been recovery also in some of those cases. But you have to be very, very prompt, and it has to be the first 6 hours of treatment which would matter. And they sometimes can recover. But if it goes beyond the first 6 hours period, then the chances of any recovery would be very, very bleak. So the treatment in this and would consist of some thrombolytic agents, plasma, the tissue plasminogen activator. You can use streptokinase injections. You can use those, right? Heparin you can use. I mean, these things I have personally tried. I have tried heparin. I have tried streptokinase. Unfortunately, those cases didn't really survive, or I had to euthanize, because most of those cases, almost all of those cases, came to me at a much later stage. They came to me after almost 24 hours, and by that time, the chances of recovery become very bleak. But if the cat comes to you immediately in the first 6 hours, you can try heparin, you can try streptokinase injections. Um, there are a lot of articles, there are a lot of research articles which are there on the internet, where you get the exact dosages of these injectables, and there is absolutely no harm in trying, because either you try or you end up euthanizing them. So before you think about the step of euthanasia, we can at least give it a full try. So you think about heparin and streptokinase. Prognosis, as I said, is often poor. Often it is some underlying heart condition, HCM, DCM. Rethrombosis is also common if able to get through the first episode. So that is why the prognosis overall is not good. Prevention, well, aspirin was used previously. In fact, a lot of places it is still used. I would say still it is a good drug, but in my next slide, which I'll show you, the new age drug is clopidogrel. The, this clopidogrel or Plavix, you get 75 mg tablet, and you give 1/4 of the tablet, which would mean 18.75 mg once a day orally per cat. So this is a new age drug for prophylaxis. So even in cases of HCM, when it crosses the mild to the moderate form, you can think about using clopidogrel. In all cases of HCM, DCM, this is a prophylactic drug, so that the clots, they are not formed, because most of these cases of systemic thromboembolism are those cases which have some underlying cardiac disease, right? So aspirin and clopidogrel are two prophylactic drugs which you can think about. Clopidogrel I personally have used quite a lot. I generally have seen no side effects, works pretty well, very safe, very easily available also now. Coming to the last slide, well, friends, these are some of the cardiac medicines from Oriheal. Pimotone, which is pimobendan, you can use in cases of dilated cardiomyopathy. Torretine plus, in a lot of these cardiac conditions, we can all use this. This is a good nutraceutical supplement. Recarpiol wet has furosemide in the syrup form. So in cats, the dosing with Lasix becomes a problem. So here we have a good product in the form of syrup. So the dose calculations become very simple. And Benzavit, which is benazepril, which is a commonly used ACE inhibitor, has minimum renal effects, renal side effects. Again, uh, these personally I am also using, and I have had good experience with using all of them. I come to the end of my presentation. I would like to thank all of you for the patience today as well as in the previous seminar. Any questions, please feel free to ask. We are here to learn. We are here to learn together. And thank you very much once again.